Hi, everybody. Now that I see I'm recording and my audio is on, I will go ahead and share my screen. So this is continuing our general surgery lecture, and I'm starting on page 434. So we're going to start with an appendectomy today. Very common procedure. You're going to do many of these. So make sure you are familiar with it step by step. Another case in here that you're going to do so many of, even more, are laparoscopic cholecystectomies. So that's removal of the gallbladder. Make sure you know both terms and that you can say them and pronounce them easily so you look like you know what you're talking about when you go in there as a student. So let me start with laparoscopic appendectomy. So on this one, it's going to focus on your two options, or I'm going to focus on your two options for entry into the belly. So you'll have two options on here under the surgical procedure, and hopefully you remember it from minimally invasive surgery. So your two options are going to be the Verres needle and the Hasson technique. So make sure you're paying attention to both of those as you read through this procedure step by step. But to get started, so acute appendicitis is usually what we're going to have these patients come in for, and that's usually caused by an obstruction in that lumen. So remember, your appendix hangs off of your cecum, so it still has a lumen inside of it. And if it becomes clogged, it can become inflamed, and then you have appendicitis. So then we are in the operating room in the middle of the night taking out an appendix. So know that these patients usually come in with right lower quadrant pain. So that's at the top of 434 on the right side of the page, localized in the right lower quadrant. That's where they're usually going to have their pain. Now, as far as the case, all the laparoscopic equipment, you should already know what you need because we went over that in minimally invasive surgery. So everything you need for laparoscopic is the same, especially as the surgical tech. You need a camera, a light cord, insufflation tubing, and an endoscope. All your laparoscopic instruments will come with that also. And I'm going to point out on this slide the specialty instruments. So that's what I want you to pay attention to. You should already know where it says equipment, instruments, and supplies, all the basics. You should know that. So let me point out the special ones on my slide. So to actually get that appendix off, you're going to need the stapler that's pictured here. So an endoscopic linear stapler, and the linear part is important. That is the line of staple that we're making, and it's a linear, it's making a straight line. Some of them are circumferential, so make sure you know it's an endoscopic linear stapler. So you will be loading that cartridge, that stapler, in there and taking the retainer out so they can shoot that staple load, take the appendix off, and take that as a specimen, and then it's all nice and sealed up. Nothing is oozing into the patient's abdomen. Now, to actually get the specimen out, you're going to use this endo pouch. Endo pouch. So if you look at supplies unique to the procedure, it says specimen pouch. So the actual term on the box will say endo pouch. So now you know both terms for what they're going to pick up that specimen with. So you're going to very skillfully drop the specimen into the bag. They're going to cinch that string closed and pull that specimen safely out through one of those trocar incisions. So they usually have to take the trocar out and then pull that specimen out, and it's already in a bag for you. Very convenient. So endo catch and endoscopic linear stapler. So when you think appendectomy, I want you to think stapler. When we get to the cholecystectomy, the gallbladder, your most common procedure, you will see that that one's going to have a clip applier. So this is what I'm talking about when I say a specialty item. They're both laparoscopic cases. You both need the same equipment in the room, the same surgical instruments and supplies like a camera and a light cord, an endoscope, all those things are the same. So what's different? What do I need to focus on as the scrub tech to have in the room? Well, for an appendectomy, I need a stapler. For a cholecystectomy, I need a clip applier. So I will point that out to you. Okay, looking at the surgical procedure, I'm not going to read through it because it goes step by step for you perfectly. So I want you to, again, pay attention to the difference between the Verres needle method, using the Verres needle to insufflate the belly with CO2, versus the Hasson technique. You'll see with the Hasson technique, they usually use a 15 blade because the incision is a little bit bigger, and it's periumbilical, so around that umbilicus. Okay, so looking at 434, where it's right before the Verres needle method, it's reminding you of the space that is created on laparoscopic procedures. So this is review for you. That space that it's created with the CO2 is called pneumoperitoneum. So hopefully you remember that and you can pronounce it correctly, just like appendectomy and cholecystectomy. So I want you to go into externship looking like you know what you're talking about. So make sure you can pronounce these words also, at least the names of the procedures. Okay, so on page 435, again, it goes through the procedure step by step, what they're going to retract out of the way, but you know they're going to be removing the appendix, and you know exactly where that is, right lower quadrant, and it hangs off of the cecum. So pay attention to what instruments you're going to be using step by step, but look down at number 7, your procedural consideration. I want you to know that a lot of the time on appendectomies, you will not have an assistant with you, so it's just you and the surgeon. So that means you're driving the camera, and more often you are holding this grasping force up. So basically you're retracting. So they say hold this while they are making the cuts and getting that appendix removed, resected. So just know that, again, on number 7, procedural consideration, you are going to be assisting a lot on this case. So the point for you is you want to have everything up on that Mayo stand that you need, because you're going to be holding instruments, so you're not going to be able to reach back to your back table very easily on this case. Flip it over to page 436. So if you look at number 9, that's your other reminder that you're going to use an endoscopic linear stapler to get that appendix removed. Okay, look at number 10. I want to point this out for you. I need you to know all 3 methods. So according to the surgeon's preference, the appendix can be removed by an endoscopic linear stapler as pictured, a ligating loop instrument, it wraps a loop around it to ligate it that way, and a suturing instrument. That suturing instrument would be called a purse stringer, by the way, because it allows that purse string suture for appendix to happen with a very cool device. So I want you to know all 3 options, A, B, and C. More importantly, I want you to know that we use option A now. We go with that endoscopic linear stapler almost all of the time. Okay. After that, again, pay attention to your wound classification. So if that appendix, it came off of the cecum, right? That could be dirty. So that's why we are switching this to a class 2 clean contaminated case. Also, you got to watch for spillage. On certain cases, if there is actual spillage coming out, that's going to change your class wound classification. So pay attention to that. That leads me perfectly into the next page, 437. So if it is infected, it's an actual infected appendix, they're going to do it open, first of all, but you want to have culture swabs available. So look where it says supplies unique to the procedure. You're going to need aerobic and anaerobic culture tubes, and luckily I talked about those culture tubes last week. After that, you'll also see some surgeons are going to want to irrigate with antibiotic solution because of that inflamed and/or infected appendix being in the abdomen. Okay, so I'm going to keep going with appendectomy, but it's all pictured for you in the book step by step. It is probably the easiest procedure that you can do. What I want you to know is if they were to do an open appendectomy, we are going to use the McBurney's incision. That incision is almost only for appendectomies because it hits that right lower quadrant perfectly. So if your appendix, your laparoscopic appendix case goes open, you'll have to quickly get what they need and instrumentation and lap sponges, things like that up on the field because you're ready for laparoscopic and you need to quickly switch to be ready for open. Okay, if you switch over to page 438, so like I said, you will see what it looks like hands-on and you can see that anatomy a little bit better and how they're going to mobilize the appendix before they remove it. Now, let's talk about what's different with open. Look at number 5. So it's talking about using a 3/0 absorbable suture to do this around the base of the appendix. And I already gave this one away for you. It's going to be a purse string technique. It says closed in a purse string manner. That works too, but it's a purse string technique because they're going to go all the way around the lumen to where there's 2 strings on the side and you can pull those strings and it tightens the circle just like a purse string. So purse string suture. Make sure you match up McBurney's incision and purse string suture with an open appendectomy. Okay, looking at number 6, it is reminding you one more time. Remember, if it says it twice in your book, it's very important. So the appendiceal stump is inverted, so you can do that purse string suture. So read through that paragraph, know how they're going to do it if it's open also. That procedural consideration, it's telling you if it's infected, which it usually will be if it's open, then you're going to have to pass off and or separate those contaminated instruments. So your book says a lot of things like that, like pass off the instruments. Many places do that. Some places like to just have it separate, just like a bowel case where you have a separate Mayo with all your dirty instruments. You can do the same thing with cases like these. Okay, so make sure you read through laparoscopic and open appendectomy. My slide got stuck. Okay, now we are ready for anal rectal surgery. So I'm on page 440. And for this one, you are really going to want to pay attention to your stoma types. Now, we talked about stomas a little bit yesterday, creating an opening for a patient, but there's so many different ways to do it. So look at your different options like loop ileostomy and end loop ileostomy. They're all just a little bit different ways of handling bowel pathology is the best way to put that. So make sure you read through your different stoma types. That's table 14-9. Okay, so anal rectal surgery. I went over some of these instruments in the classroom. I just want you to be able to recognize them. And then I've got a picture of your hemorrhoid banding over here, and I will go over that because that's a common case. So after your stoma types, let's go to page 441, anal rectal pathology. So you need to know what a fistula is versus a fissure. So an alternate hole, a fistula, versus a fissure, a crack, because you will see both of those. Also look at pilonidal disease, pilonidal disease. So pilonidal cysts, we have a lot of these. They'll get a cyst or a lump, lower back, right before your butt crack is where it is. I don't know how else to put that in layman's terms for you. So that's exactly where you're gonna get pilonidal cysts. So this says pilonidal disease. So you'll have an abscess right there on that very lower back where a lot of sweating happens, right? So there's a lot of sweating happening there and it's hard to clean well back there. So that's why we get a lot of cysts in that area. So hopefully you are mentally prepared to do rectal cases because they're very common in surgery too. Next, we will hit hemorrhoids, which you'll do hemorrhoid bandings that are pictured here. So this is a special device that basically allows a band to get wrapped around it so it can get ligated off that way with the bands. So that allows us to get rid of those hemorrhoids for those patients with this banding. So hemorrhoids, know the definition in your book, so pay more attention to this one than the others. So this is going to be dilation of the submucosal and subcutaneous venous plexus. So venous plexus, that's a band of veins, right? So you've got a big plexus of veins, a big grouping of veins. And unfortunately, we can see that coming out of the patient and it is and appears to be a hemorrhoid. So when they see that, they're going to investigate that in the doctor's office, and if they can make a plan of attack, they can go ahead and schedule surgery. I put the not laparoscopic, I put the hemorrhoid banding on here because that is the most common way for us to fix those now. So again, for your textbook definition, know that this is going to be congested and dilated veins. It's a venous plexus, and know the type of tissue. It's submucosal and subcutaneous tissue. Okay, so after that, I will actually go ahead and flip the page. So page 422 goes right into hemorrhoidectomy. So 422, this picture matches it perfectly because these are the instruments you're going to be using. Hopefully you recognize this Sawyer retractor right here. And this one can be self-retaining because you see this little knob on the side. So they can open it. So they're going to push the handles closed so that the retractor opens, and then they can lock it down into place so they can continue to do their surgery without that collapsing back. So for hemorrhoids, you need to read over your anatomy. So at the bottom of 422, what I just talked about, how it's a mucosal membrane, how it's going to contain arteries and veins, and that vein, those veins that are there is a venous plexus. That's the only thing that's left out of that sentence down there at the bottom. It just says veins instead of venous plexus. So read through that anatomy. Now you can go over to page 443. So it gives you another basic definition for you of that. So abnormal enlargement of the veins. When it says enlargement, I want you to also put dilation. So they're not just getting bigger, they're dilating. So abnormal dilation of these veins. Okay, let's look at equipment, instruments, and supplies. So because of where we're working, the surgeon's going to need a headlamp. You need to know that, a headlamp. And then look at your rectal set includes. I want you to know everything that your rectal set includes. So anoscope, rectal speculum, rectal dilators like we looked at in class, pile forceps, buoy, pile forceps, and the crypt hook or crypt hook. So you know that hook will be used for fistulas to fix that hole, rectal dilators to dilate before we can get a speculum in, and then to actually look inside, we'll use that anoscope. So make sure you know what that rectal set includes right here on page 443. Okay, and then anorectal procedures, the position. Very easy to remember because we don't use it very often. Jackknife or Kraske position. Make sure you know both names, Kraske and jackknife. This is most often used. And we talked about your second option today. That is lithotomy. So again, anorectal procedures is going to be Kraske, aka jackknife, or lithotomy. So we can access what we need to access for surgery. On supplies unique to the procedure, note that it says KY jelly lubricant. So you need lubricant for any type of rectal surgery. We don't want to cause more damage while we're helping our patient. It talks about tape for retraction, and they do have that. I more want you to think about what you need on the ScrubTech end. So where it says KY jelly lubricant, I'd like you to add that also the surgeon can dip the instruments in betadine before they use it. So jelly and betadine. Okay, so you can flip it over, and I want you to read through this one so you can see one way that they can remove hemorrhoids. The other way is pictured here for you. It's a special device that puts a band around that hemorrhoid so that it can come off and be resected on its own. It causes less pain for the patients. That's why we do banding. For this case, know that you could still have specimens. No, all the way down at number 9. This causes a lot of bleeding, so you might need a hemostatic agent, and you basically use it as a dressing because there's not really a place to put a dressing for anorectal surgery. So sometimes they will give them a special pad underneath them, but it's also going to be a lot of bleeding. So they could put gel foam or Surgicel, which are hemostatic agents, if you don't remember from surgical pharmacology. They can put that inside to help lessen the bleeding while the patient is in recovery. Okay, that's anorectal surgery. Now into the liver surgery. So I love liver surgery because it's so vascular. It's really cool. They're big cases, so a little overwhelming the first time, can be a little stressful, but such a cool thing to see. Definitely worth the effort and the studying that needs to go into it. So you can read through your select pathology for liver and the biliary tract. I would like to flip over to page 446. So liver resection. So I did many liver resections that were for cancer. So we removed just a small portion of the liver. I was excited to find that you can remove large portions of the liver and that it regenerates itself. So the liver is pretty amazing. You can resect large portions of it. Now on this one, I made a list for you of what all you need, specialty items. I don't usually do that. I don't usually do that because in surgery, they're going to give you verbal commands and expect you to remember it. So I try to do that same thing in the lecture. But if the list gets a little too long for you to remember, I make a list for you. So on the slide, know everything that's on that list, but I will go through our page first here, 446. So on liver resection, your paragraphs above the procedure, go to the right side of the page. So it's talking about if there is a tumor, like I was talking about, if we are removing a section of the liver for tumor. So if it's where it says major hepatic vascular involvement, major hepatic vascular involvement may make resection unattainable. That's the part I want you to know. So basically, it's so vascular, it depends on where that tumor is. And if it is near that major hepatic vessel, then sometimes we can't resect it. Sometimes we're just not going to be able to resect all of it. So if you hear the term debulking, that's what they're talking about. They can go in and debulk part of that tumor, take parts of it out, but they can't get it all. So they might just debulk it if it has hepatic vascular involvement. So make sure you know that section. So if it's a large tumor or has hepatic vascular involvement, it might be impossible or unattainable, as it says in your book, to resect that. Now also know that liver resections, there's different things as you read through the pathology. There's different ways to have cirrhosis of the liver. So this isn't always alcoholic cirrhosis of the liver, and you need to know that. So let's look at cirrhosis, the next sentence. Cirrhosis of the liver is associated with hepatocellular carcinoma. So you need to know cancer, carcinoma, and as a result of viral hepatitis or alcohol abuse. So again, alcohol abuse is not the only way to need a liver resection. Okay, after that, let's go through the procedure. So liver resection, your anatomy, you should definitely read through. Look at your second bullet point. It's covered in a fibrous and serous coat called the Glisson's capsule. You need to know that. The liver has a special look to it, and that Glisson's capsule actually glistens. So that's what made it easy for me to remember about the liver. And it's divided with that big falciform ligament. You need to know that too. The rest of it, I want you to read through it so you understand that it's a very vascular area. And because of that, you're going to need different equipment, instruments, and supplies. So let's look at page 447. So you want to have Cell Saver available. This allows us to use our own patient's blood and recycle it through the Cell Saver machine and give it back to our patient. So this is pretty amazing technology. We can use this on a lot of different cases, like heart cases that are very vascular, and we can have lots of blood loss. So on liver cases, you want, if possible, to use Cell Saver. After that, you can also see where it says hemoclip appliers and ligating clips. You'll need lots of hemoclips for this because there's so many little vessels you're going to be clipping off before you can actually resect even partial of that liver. On the next section, supplies unique to the procedure. You'll see gel foam and Surgicel, so hemostatic agents to stop the bleeding, vessel loops to tie around vessels and retract them out of the way, extra suction tubing, so you have 2 suctions. There's so much blood, you need that suction so you can have visualization. And then you're very deep in the belly, so you're gonna need a long Bovie tip. Okay, after that, look at your practical considerations. So your liver is highly vascular, as I've said, so have several types of clamps and a large number of ties. Okay, so looking at the picture in your book, you will see a big retractor. So this is your liver retractor, and that is almost enough laps to do a liver resection, but not quite. So you start off with a lot of laps, you're gonna use a lot, and you'll have to ask for more throughout the procedure. This liver retractor was very difficult to count There's definitely more pieces than the Bookwalter, so you just have to think one piece at a time and not think about what the next step is. Just focus on one instrument tray at a time when you're counting those things. Okay, so something extra on this one. So I've added argon beam on here. Now you'll see that they have that as an option, but they don't always use it. Not all surgeons use it. So describing the argon beam was difficult for me, so I found a very good picture. I always describe this as the fire stick because it literally looks like it's shooting fire. So because that liver is so vascular, sometimes after they resect part of it, they need to just score that area and char it. So they will use that argon beam to shoot fire on it and just score it all, so they won't have any post-op bleeding and post-op bleeding complications that would bring the patient back into the operating room. Okay, so read through this procedure. This is not one you need to memorize step by step like the appendectomy and the cholecystectomy, but you want to be able to read through it so you understand why you need so many vascular supplies for this one. Okay, on 449, you will see a good picture of the ductal system of the liver if you need help with that anatomy or a review. Okay, I think I'm done with the liver resection. Now we are on to cholecystectomy. Again, you have to know this one step by step. You need to know what they're cutting, what they're clipping, what they're cutting, and what they're trying to preserve and not hurt during this case. Those are the things that you need to know. These pictures on here are amazing. I have a really good outline of the anatomy, and including that triangle of Collat, that danger triangle that they have to expose during this case. So these pictures will absolutely help you with the anatomy if what in the book is not helping you. So please utilize this resource. So let's get into a cholecystectomy. So let's actually flip over to page 450. Page 450. So let's look at conservative treatment for cholelithiasis. So before we get into the surgery, let's look at other options. What can we do without cutting into the patient? Well, we can do an ESWL. That's ESWL. So I will read you the definition: extracorporeal shockwave lithotripsy. So lithotripsy is making that shock wave, and you'll just hear a knocking sound throughout this case. So this is non-sterile, there's no incision, there's no opening, but there has to be a circulator and a scrub tech in the room, an anesthesia provider. The patient is asleep. So we're gonna do this in the operating room. So this sound that you hear, and it's very loud throughout the day, you know somebody's doing lithotripsy in that room, and that sound is breaking up that kidney stone into little pieces. Because why do surgery if we don't have to? So they can look at the size of it and determine whether they can break it up with that lithotripsy or not. So be familiar with ESWL. Know that that is extracorporeal shockwave lithotripsy. Okay, so again, this is going to get the fragments of the gallstones into little pieces, so it's small enough to pass through that cystic duct. So definitely study this anatomy and know it very well. So they're going to pass down the cystic duct and the common bile duct into that alimentary canal. So that way it can just be expelled naturally instead of removed surgically. Okay, so after that it gets into an open cholecystectomy with cholangiogram. They're not usually going to schedule it open. They're going to schedule it laparoscopic, but it can convert to an open case. So I want you to know how to do the open case also. So open cholecystectomy with cholangiogram. Know your first sentence, your anatomy. So gallbladder is located in the fossa on the inferior surface of the right lobe of the liver. So you should already know it's near that right lobe of the liver. So hopefully this is anatomy review for you. But if not, I've included lots of good pictures. So after that, you'll see your Hartmann's pouch is located at that junction with that cystic duct. So if you read Hartmann's pouch as you read through it, it's right near that cystic duct. It's that little pouch before the cystic duct. After that, you should definitely be familiar with your common bile duct and know that it's formed by the joining of two ducts. So the joining of the cystic duct and the hepatic duct. Those join together to make the common bile duct. So if you need a note on the side, you could put cystic duct plus hepatic duct equals common bile duct. So they will merge together, and once they merge together, it deserves a new name, so it is now the common bile duct. Okay, after that, you'll see your triangle of Collat, and there is a good picture in your book, but I gave you a better one on the slide. On the triangle of Collat, know that this is where they're finding the anatomy to do the case. So they're gonna find the cystic duct and the hepatic duct, and then they're gonna locate that cystic artery. That's what they're going to find in this case. Okay, after that, look at your last bullet point on page 450. Last bullet point. Cholecystitis is the common result of an obstruction of the cystic duct by gallstones. So you probably already knew that part, but make sure you know that those gallstones can get stuck in that Hartmann's pouch. It can also get stuck in the cystic duct. But those are the two places where it's going to get stuck. Okay, after that, you can look at page 451. More pictures, and it goes through even more of the reason why they're coming in to have this surgery done, of that acute cholecystitis. So a lot of patients are going to have a lot of pain in the right upper quadrant this time. So remember, appendix, it was lower, and with the gallbladder, it's going to be upper, so right upper quadrant. Okay, on this one, look at supplies unique to the procedure. So you'll see that we're going to be doing a cholangiogram sometimes. So they're going to be verifying where they are with x-ray. They're also going to be making sure there's not any stones where they're not supposed to be, right? So it's kind of an exploration to see if there's anything else, if there's more stones to get, and to see that anatomy clearly. So where it says cholangiogram supplies, you need to pay attention to where it says syringes. You'll need two. One for saline and another one for contrast. Now I'll make a note for you, but near your contrast, you can't have any bubbles come out of this contrast at all. If there were bubbles, it would look like stones in the x-ray. Because remember, that's one thing that we're looking for. We're looking to see if there's stones anywhere. So if you gave them that contrast in a syringe and you didn't get all the air out and there's little bubbles, it's going to appear as stones on the x-ray. And then they could do a common bile duct exploration for no reason and find no stones. And you don't want that to happen. So make sure you make that note, and it will repeat it multiple times for you in the book. No bubbles on your contrast. Oh, I almost missed it. So look at your equipment, instruments unique to the procedure. Here is where I told you your unique instrument you will have. That's a HEMA-Clip applier. So HEMA-Clip applier to ligate, because on this one we are going to be clipping and then cutting with a scissor. Okay, so it goes through the procedure open. So on your surgical procedure, page 452, top of the page. So there's several incision options. I want you to pay attention to right subcostal or the Coker, because that's what's most preferred, most common. So again, open cholecystectomy, right subcostal or Coker incision. After that, it tells you how they're going to expose that gallbladder, and as with any abdominal procedure, if there's any adhesions, they are going to pull those down. Look at your procedural consideration. So on this one, you'll see that if it's open, you'll have to put a retractor on the liver, and I've told you guys before that they like that Harrington retractor for the liver. So if you don't remember which retractor that is, it's the one that looks similar to a Deaver, but it's got a hard shape at the end. So Harrington, like Sweetheart retractor. Okay, so instead of reading through it step by step, because I know you will, I want to focus on what are they cutting, what are they preserving, because that's what I want you to know. You need to know it step by step again. You're responsible for everything that is in your textbook. But I want to focus on what are we cutting. So after we get access, all of that stuff, we can see everything, it's all retracted. Look at number 6 on page 453. The cystic artery is then doubly ligated, and then the artery is transected. So cystic artery cut. Then look at number 7. The cystic duct is going to be carried out in the exact same manner as the cystic artery. So we will be clipping and cutting. So again, we're cutting the cystic artery on number 6 and then the cystic duct on number 7. Those are the 2 things that we are cutting. Now we can look at number 8. So if necessary, an intraoperative cholangiogram is performed. So this is where you're going to have that contrast medium so that we can have that contrast and have it light up on X-ray to see if there are any stones and to secure that we're in the correct place also. So if necessary, intraoperative cholangiogram, and it tells you how they're going to do that if it were open. But the idea is we're putting a catheter into that common bile duct. So if you'd like, next to number 8, if you're not understanding what they're going to see in a cholangiogram, you could make the note. It's going to show the structure of the common bile duct and the hepatic duct. So one more time, that intraoperative cholangiogram is going to show them the structure of the common bile duct and that hepatic duct. Okay, with that contrast solution, I already told you no bubbles. So let's look at your last bullet point on the page. And you can look at the last sentence also. Tap the syringe gently to make the bubbles rise to the top and gently remove by pushing the plunger. So yes, this means you have the side of your table and your syringe and you can just tap it to get those bubbles to rise to the top, right? Another thing you can do is pull back on that plunger a little bit and then push forward. You can draw up a little bit of extra contrast medium, and if you push forward and you lose a little bit of it, that's okay. What's more important is that there are no bubbles in your contrast medium, because that is going to appear as kidney stones, that's going to appear as gallstones to the surgeon. So make sure you know on that last bullet point to add, the bubbles are going to look like stones on X-ray. Okay, page 454. So after that, let's look at number 9. So they can probe the duct gently. Sometimes bile will ooze out of it, but the cholangiogram catheter is going to be introduced into that duct. So again, that introduced into the duct, and they will secure it with a ligating clip. So I'm pointing this out because you know ligating clips are for ligating vessels, so they're going to clip those on that cystic duct and artery, but here they're going to use the ligating clips to hold that cholangiogram catheter, the tube, into place. So it's clipping it on so it stays into place. Okay, after that, let's look at number 10. Number 10. So the cystic duct is going to be aspirated until bile is drawn into the syringe and the duct is flushed with saline. That's the part I want you to see. The duct is going to be flushed with saline. So here's where you need to make a note on the side. It doesn't say it word for word, so I will say it for you. They're going to flush it with saline to test the patency of the cystic duct. So again, the patency, the openness, because if it's closed, that's not going to do us any good, right? It needs to be patent or open. So saline is going to be pushed or flushed to test patency of that cystic duct before contrast is injected. So that is why it says the duct is flushed with saline. So after that, the dilute contrast medium is instilled into the duct and that X-ray is taken so we can see the imaging. Procedural consideration, remind the surgeon what is inside that syringe every time before you hand it to them. That is very important. That's a good way for mistakes to happen by not communicating. So always communicate medication when you're handing it over. After that, you can look at number 11. So the X-ray should reveal the structure of the common bile duct and the hepatic duct, just as I said. This will also show if any spillage has happened or if any gallstones are present. Okay, look at number 12. You'll see what they're going to do next. They're going to apply some traction and then score that gallbladder off of the liver. So a lot of cautery is going to be happening. A lot of people use electrocautery or hook cautery but there's different options to get that gallbladder off of the liver bed. Okay, then they're going to remove the specimen. Sometimes you'll need an endo-catch bag, but not always. So that's why I didn't include that picture here. They can sometimes get it out through that belly button incision. So look at number 14, specimen is removed from the wound. The area is irrigated, checked for hemostasis, and the abdomen is closed. That's your open cholecystectomy. Laparoscopic cholecystectomy. I wish I had seen these pictures when I was in school so I could learn the anatomy before seeing it in real life. Surgeons do sometimes point at something and say, "What is this?" to a student. And so luckily I got close. So when he said, "What is this?" He hadn't ligated it yet, but I saw a clip go on. And I should have known because of that clip that it was the cystic duct. So that's what they're going to clip first. But I guessed artery. I was incorrect, and they schooled me on how to see the anatomy a little bit better. So I've got an animated picture and then a real picture of a laparoscopic cholecystectomy, so you can see that triangle of Collat in the anatomy. But we're doing the procedure the same way, right? The same cuts are being made. We're still cutting the same thing. We're still trying to preserve and protect that common bile duct while cutting two things during these cases. So make sure, I'm going to not repeat it again and give you all of the answers. Make sure you know what they're cutting and then what they're trying to protect. So we're trying to protect that common bile duct. And you need to know what they're going to be clipping and then subsequently cutting right afterward. Okay, you can flip it over, page 456. You can look at number 1. You'll see that they are usually going to use the Verey's needle method with this one. So pneumoperitoneum is established by inserting that Verey's needle before insufflating with CO2. The rest of the procedure, like I said, same steps. So look at page 457. The cystic duct is going to be divided. And then you can look at page 459. The cystic artery is also going to be divided. It even tells you exactly how many clips are going to be on there so you can prepare. So for example, page 459 on number 7, it says 3 hemoclips are placed on that cystic artery and then divided. So it gives you really good specifics so you can be prepared as the script tech. And then you can look at number 9. As I said, if it's laparoscopic, they can pull it through that umbilical belly button port where that trocar is. So that will help them get it out. And if they can't get it out that easily, they can put it in an endo-catch bag, still taking it out through that belly button, but that allows the specimen to be contained. Because what if that gallbladder is filled with gallstones that could spill out into the abdomen? So a lot of surgeons like to be on the safe side and put it in an endo-catch bag before taking it out. Your procedural consideration, I always have the knife available when it's time to take the specimen out on a laparoscopic case. They might have to widen that incision. If they do, they'll use a 15 blade instead of that 11 blade. Look at your wound classification on this one. It can change based on whether it gets contaminated or not. So if they grab onto that gallbladder and a big hole forms and it just spills bile and gallstones out into your abdomen, that has become contaminated, and that is changing the classification of your wound. The next part is your pictures of step-by-step of the procedure. I cannot stress it enough that you need to go through a laparoscopic cholecystectomy step by step by step and have memorized what they're going to do. So when you go out to externship, you know what is happening next, minimum on a gallbladder case. That's your most common procedure. So that brings me into pancreas surgery. I love talking about pancreas surgery because I tried so hard to get in on a full Whipple, and I will describe that struggle, even though it's not for your test, but it's good information for you. So let's look at the book first, Surgery of the Pancreas and the Spleen. So cancer of the pancreas, that's usually why we're going to do a Whipple procedure. So you can go ahead and look at, I'll pronounce it for you this one time, pancreaticoduodenectomy. So I said it very slow, pancreaticoduodenectomy, technical term. You need to know it as the Whipple procedure. So I told you need to know how to pronounce cholecystectomy and appendectomy, correct? This is one they will forgive you on because you're just going to call it a Whipple procedure. So one last time, pancreaticoduodenectomy, if you want to pronounce it correctly, but you can just call it a Whipple procedure. You need to know that first sentence. It's performed for managing tumors of the head of the pancreas, the most common site of pancreatic cancer. So we are not removing that whole pancreas. We're talking about removing the head of the pancreas. Look at your table 4-13, pancreatic tumors. So know that pancreatitis is associated with both primary pancreatic tumors and metastases. So that means cancer that is metastasized from other places inside the body. Look at your last bullet point in that table. You'll see this will be treated with a Whipple procedure. The majority of patients, 80% with pancreatic cancer, never undergo surgery. So here's where I have to add to pancreaticoduodenectomy. On this one, I did many that were called peek and shrieks. So unfortunately, you make the incision, you look at the pancreas, the cancer has progressed too far. Debulking or taking part of that tumor is not going to help the patient. It's going to cause them more pain. So we immediately close back up. So unfortunately for me, I did 3 or 4 of these in a row. So not only is that sad to see a patient we can't help, but I wanted to challenge myself. A Whipple procedure is very difficult to set up. It takes lots of suture, big open belly case, deep in the belly. And that's what I was scared of as a new employee, was big open belly cases like a Whipple. So I was determined to do one before I got off of orientation. So right after I got off orientation, I did get to do one all the way through, thank goodness. But sometimes you will have to where they just peek and they look in and they say, no, we're gonna have to close it back up. The cancer has progressed too far. So on pancreectomy, know that the pancreas is divided into 3 different regions: the head, the body, and the tail. If you flip it over to 466, you'll see that you need to pay attention to a little bit of anatomy. I'm going to skip to where it says the islets of Langerhans. So you need to know these are the endocrine secreting glands. So this only accounts for 1% of the pancreatic mass, but you still need to know the term. So the islet of Langerhans. After that, you can look at equipment, instruments, and supplies. So on this part, you're going to need a major instrument set. You'll need gallbladder instruments. You'll need GI linear stapling devices. We got to see those in the classroom today. Yankauer and pull sections. Hemoclip appliers, lots of those. And self-retaining retractor. So we're deep in the belly, so I'll go ahead and say Bookwalter retractor. The Balfour is not going to be good enough for this one. Then there's a great picture of your anatomy for you to go through. I do want you to recognize this anatomy that's pictured on my slide. So the parts of the pancreas. So it comes right off of the stomach into the duodenum, and then you'll see the pancreas right underneath it. So I gave you a real life picture so you can see that it doesn't really look anything like what is in your book. So a Whipple procedure is very long. This is not one that you want to memorize step by step. So you should read through it, see why it's so vascular, why it's such a long case, and hopefully you'll also see why I needed so much suture for this case. I believe I opened over 100 suture for just a Whipple procedure. Okay, so that brings me to page 469. Oh, sorry, 469. So your Whipple procedure, know the term, and when you flip it over, this part is easy. On page 470, know that your Whipple procedure can take 5 to 6 hours, and transfusions are common on these cases. Now where it says take 5 to 6 hours, I will have to add my personal experience there. I've definitely seen 8 hours. So it can be more involved, it can be more complicated. It also makes a big difference on how many cases your surgeon has done. They're going to be a lot faster at it if they have done many of those cases. So again, you can read through that procedure, but it's not one that I want you to memorize. Now we can look at the spleen. So splenectomies. On the spleen, I want you to know the spleen on page 472. The spleen is the single largest mass of lymphatic tissue in the body. So because of that, it's a lot of tissue, but it also has a lot of arterial blood supply. So this one is extremely vascular also. Splenectomy, go to page 473. No, because of all that bleeding, you're gonna need hemostatic agents and active drains. Where it says active drains, that means it's got a vacuum suction somehow. So a hemovac drain is a good example of where it's active and it's gonna be pulling that extra blood out of the patient. So splenectomies, I will just add that a lot of these are done for traumas, especially car accidents. So yes, you can live without your spleen, but it's a different lifestyle, so you can read about what it's like to live without your spleen afterward for these patients. But splenectomies, I have done almost all traumas. You can do it for cancer and for other reasons. What I want you to know, very vascular case. And if you do a splenectomy for a trauma, you're gonna need lots of extra suction and lap sponges very quickly, and lots of silk sutures to stop bleeders. Okay, now I can go to hernia repairs. So hernia repairs on page 478. I want you to know the different kinds, and I want you to also see how they're doing it now. They do lots of open hernias, but many of them can be done laparoscopically now, and I wanted you to see the option for laparoscopic. So let's pay attention to, on hernia repair, your third option in italics, endoscopic total extraperitoneal patch, where it says TEP. So this is increasingly common today, as I said, referred to as laparoscopic inguinal hernia repair. So that's what I would call this, a laparoscopic inguinal hernia repair. You need to know the other names. So now I've pointed that out for you, endoscopic total extraperitoneal pouch. So that's a laparoscopic way to fix our hernias. Okay. That brings me right into inguinal hernias. They're talking about open on this one. So you see laparoscopic on your page. You also see the picture pointing out all the different options for hernias. So you do need to know all the different options and different kinds of hernias, like direct and indirect, umbilical, femoral, going through all the different types of hernias. Okay, so look at page 479. I want you to know McVeigh inguinal herniorrhaphy. So hopefully you remember rhaphy is the repair of a hernia. So on an inguinal herniorrhaphy, you want to know some of the anatomy that you're going to see. So you will come across that Scarpa's fascia. So that's that sheet that is attached to your iliac crest, like I pointed out to you before. And you're also going to see the Cooper's ligament. So that Cooper's ligament is that periosteum of the pubis. So make sure you know both of those two anatomy things that you are going to see on these cases. I want to also point out, where is it? On your inguinal hernia, the spermatic cord. So I'm pointing out the spermatic cord because look at your supplies unique to the procedure. Do you see where it says Penrose drain? They can use that Penrose drain to retract the spermatic cord out of the way. So spermatic cord, they can wrap the Penrose drain around it and move it out of their way. That is an extra specialty item that you'll need to know that's specific for inguinal hernias. Okay, if you flip it over to page 480, I did it again, sorry. On page 480, you will see what I am talking about on number 4. So number 4 on your procedural consideration, it describes exactly how they're going to use that Penrose drain for retraction. After that, I want to point out on number 5 that it's good to have sponge sticks on these. Those are very convenient for stopping, to get visualization, stopping the bleeding, and just blunt dissection to push down with. So have sponge sticks available for this case. Okay. After that, you can read through the rest of these steps. Again, I got to point out the most important parts so you know what to pay attention to. So let's look at page 481. And it's talking about what they're going to do with the patient afterward. But I want you to look at this mesh that's on the picture here, this mesh. So the procedural consideration under number 9, look at the last sentence. The mesh may be moistened with antibiotic irrigation prior to placement, according to the surgeon. What I want you to know is that you need to read the directions on every package. So these packages tell you what it would like you to put it in. So most mesh will tell you to soak it in saline. If the surgeon wants antibiotic irrigation or saline, that's fine too, but you need to make sure that's okay with the directions. So any sterile item, just look at the directions and read it, or ask someone who has the experience, like your preceptor, what am I supposed to soak this in? Saline, antibiotic irrigation, what would you like it soaked in? Because you don't just want to hand it to them dry, because it's not going to be as malleable and it's not going to tack up to the patient as easily. So make sure you know that you need to moisten that mesh in some way and that you need to ask the question. So don't just go with the antibiotic irrigation that it says in your book, ask the question. Okay, after that, you'll see what I already described for you, a TEP, laparoscopic inguinal hernia repair. So know that TEP part of it. Now you'll see what the trocars look like, but I included pictures for you. Okay, when you get to 484, you can read about a ventral hernia. So this one, the anatomy is a little bit different. So I will point out that part to you. Postoperative ventral hernias, referred to as incisional hernias, usually occur on vertical midline incisions. So that means if we do a laparotomy on a patient and maybe they start moving too quickly, maybe it's just their recovery, but they might develop a hernia underneath their incision. So if you see ventral hernia, it's usually an incisional hernia. Okay, so I'm going to repair very similarly, and it's giving you the laparoscopic option. Umbilical hernia, so when you turn it over, you know where that's at. That's at the umbilicus. So let's find it. Your third bullet point up at the top, surgical anatomy and pathology. Umbilical hernias usually are in infants and are congenital. They usually close spontaneously, but if not, we can fix it surgically. So umbilical hernias, usually children that we're going to be working on. Okay, so the hernias is what you really need to know the difference between. Now read the different types in your book, but let's flip back for just a moment. Page 477. So I went directly into the procedures. You need to study this page, the hernia types. So I said that out loud to you, but I didn't give you the page number, so I had you flip back. Page 477. So example, look at the groin. It goes over inguinal hernias, and it even tells you males, direct or indirect hernias. And then if you look at femoral hernias, 97% female. So sometimes it's easy to guess just based off the type of hernia if it's male or female. So inguinal more likely is going to be a male, whereas femoral is usually going to be a female. On your ventral hernias, on that one, pay attention to where it can present. So it can present along that linea alba line or the semilunar lines. Do you see where in parentheses it says Splugian hernia? So this name, I want you to go hand in hand with this ventral hernia. So know that whole section about ventral hernias. Okay, go down a little bit further in your chart where it says direct and indirect. Direct and indirect. So on direct hernias, see where it says Hesselbeck's triangle? So can present with Hesselbeck's triangle, bounded by that inguinal ligament that I talked about, inferior epigastric vessels, and that lateral side of the rectus abdominis muscle. Here's where I'd like you to make a note. This direct hernia is going to protrude through the transversalis fascia. Now we looked at this anatomy earlier on the open belly if you need a picture of it, but I just want you to add this note to direct hernias. So I want you to add it right after that section on Hesselbeck's triangle. It's talking about your anatomy. So this direct hernia is going to protrude through that transversalis fascia. That's what a direct hernia is going to appear like. After that, look at your indirect. So on indirect hernias, look at your last section. So it starts with follows congenital defects. So indirect hernias can follow congenital defects that dilate the internal inguinal ring and pass through that deep inguinal ring into the scrotum. So that's why we're going to need a Penrose drain to retract that spermatic cord. So here's where you're going to add a small note here. So I just read this section to you, how it follows congenital defects, and dilates the internal inguinal ring, and it passes through that deep ring into the scrotum. So here's where I want you to make your note. This allows the intestine to protrude into the scrotum. So that inguinal ring not doing its job, allowing something to pass through, can allow intestines to pass through. So this is why sometimes males will have really bad hernias where they have bowel protruding through their scrotum. And your book doesn't say it word for word, so if you didn't catch that, you can write the note that I made for you. So this is why we are going in and fixing this indirect, specifically inguinal hernia that it's talking about right here. Okay, after that, I want you to look at pantaloon, because you will almost never see that one on the OR board. They're not going to categorize it as a pantaloon, but both direct and indirect hernias are present on a pantaloon. After that, you'll see femoral, so more common in females and males, as I pointed out before. Epigastric and hypogastric, you should just know your medical terminology to catch that one. So hernias above the umbilicus versus below the umbilicus. Okay, so that finishes up on hernia repairs. Now I can go to breast surgery. So although a lot of breast surgery is going to be done by plastic surgeons, general surgeons are usually going to deal with breast cancer cases and taking out breast tumors. So looking at the breast and axilla pathology, I want you to see that breast conserving surgery is possible in 90% of cases. So we're always going to try to preserve that tissue if that's what the patient wants. After that, I want to point out that men also suffer from breast disorders such as breast enlargement. So know what the term gynecomastia is. So that's an abnormal breast enlargement in males. I want you to know that that is benign. So in no way is gastrocmastia cancerous. That is benign, but sometimes still needs treatment. So go ahead and flip it over for breast surgery. You need to know your breast cancer staging. So all 5 of these, all 5 of them. So as you're reading through these, I want to point out stage 5. Stage 5 is the biggest one I want you to pay attention to because this one actually has evidence of distant metastases. So it has evidence of metastasizing elsewhere in the body besides breast tissue or just lymph nodes adjacent to it. But know all of your different types of breast cancer staging. After that, you can look at your figure 14-23, your breast surgery options. This you definitely need to know. So you can see radical mastectomy, modified radical, and then simple mastectomy. I want you to pay a lot of attention to. On the simple mastectomy, I want you to make a note. No lymph nodes are removed here. No lymph nodes are removed here. Then there's segmental, small segment, and then even smaller, a lumpectomy. So when it's talking about tissue preserving, it's talking about doing something like a segmental resection or a lumpectomy, something small. Okay, so this section, instead of going through it step by step on the breast biopsy, I want to pay attention to what's on the slide, but more importantly, I need you to add a note. So add it wherever you need to for breast biopsies. So if a breast biopsy is followed by a mastectomy, that means we took a piece, we sent it to pathology, they said, yes, it's cancerous, and now we want to do a full mastectomy while our patient is still asleep. If that happens, you will need to redrape, re-prep, and have all new instruments. This is because it's cancer. If we're going to go in and take more tissue, we could be spreading the cancer somewhere else, and we do not want to do that. So very important that you make that note, so I'll repeat it for you again. Breast biopsies, when followed by a mastectomy will need to be re-prepped, re-draped, and have a new setup with new clean instruments. Okay, now let's go through breast biopsy, the pictures. So flip over to page 490. I want you to pay attention to your second bullet point, what the surgical tech and the circulator should confirm. This is talking about specimens, and it's very important. You need to have good communication. If you are doing specimens on both the right and the left, you will see why specimens need to be passed off the field immediately. If you mix up that right and that left specimen, they could go in and do radiation on the wrong side. They could do treatment on the wrong side. You could mess up somebody's cancer treatment if you mislabel something or don't handle it properly. So please take specimen care very seriously, as I do. For this case, you'll see needle localization. So that's where you're seeing this blue dye and sometimes a needle stuck inside of the tumor. So sometimes a patient will come in the room and there's a big needle sticking out of their breast tissue. That's because they did needle localization. So let's look at that bullet point. If the patient has undergone needle localization, the procedure is going to be done in the radiology department. I need you to know that part. So they go in and they insert a needle in the radiology department just in the right spot so that when we go into surgery, we can dissect around that needle and get the full tumor out without taking any extra tissue. That's the point of needle localization. So I want you to know again that needle localization, that procedure is done in the radiology department. After that, they're going to wheel them to surgery and we're going to take that tumor out. Okay, on this surgical procedure, again, I won't go through the whole thing, but I want you to pay attention to number 1. So the type of incision they're making. Where is it? So not the first one. It says a curvilinear incision is made in order to follow the skin lines. But after that, it says along the border of the areola, a circular molar incision if it is centrally located mass. So long word, the part I want you to know, that incision is used if it is a centrally located mass. That's the part I want you to see. So again, this is for a biopsy, for excisional biopsy, if you need to make that note. So particular names for the incisions that you need to pay attention to for this excisional biopsy. Okay, after that, it goes through what I said, the needle localization. They have the needle in, we're gonna dissect around to get that specimen out. After that, let's go to page 491. So what goes hand in hand sometimes with breast cancer are lymph node dissections. That's because that cancer can spread to the lymph nodes very easily. So let's look at sentinel node biopsy with blue dye. This blue dye is not something you want to spill, by the way. It will stain everything. So let's look at practical considerations. The sentinel lymph nodes are the first nodes along that lymphatic channel. Now there's an alternate name that surgeons use that I do need you to know. So instead of lymphatic channel, they might say axillary chain. So I want you to add that note. So the sentinel lymph nodes are the first nodes along that lymphatic chain that comes off the breast tissue, or axillary chain. And you'll see why it's axillary, because it's right underneath that arm. So this procedure, the sentinel node biopsy, is frequently scheduled with a mastectomy or axillary dissection. So most of these cases go hand in hand together. If you flip it over to page 492, it will talk about the dye a little bit. So the surgeon's going to inject this blue dye into the tumor mass. This is usually completed before the skin prep is done, and if the patient is under general anesthesia in the procedure, they're going to allow the dye to travel through that lymphatic system. So it allows it to all turn bright blue, so when we get to it, we can see, yes, that's a lymph node, because these are very hard to find. they don't look like this in surgery. It just looks like a lump, a mass of tissue. So it's very hard to find. So we're going to inject that blue dye at the tumor site to see where it would spread. So if there's cancer cells spreading, where is it going to spread? We're taking those lymph nodes out. We are eliminating the chance of this cancer spreading. On this one, look at your rule of fives and be familiar with that. So rule of 5 is 5 mils of dye is injected at 5 different sites spanning a 5-centimeter diameter, and the site is massaged for 5 minutes. So they will inject with the blue dye and then massage that breast tissue to make sure it really gets all the way into those lymph nodes. So it's kind of like they're massaging the breast tissue and that axillary area to push that dye through so that we can see it when we make our incisions. Okay, after that, it goes into a modified radical mastectomy. So know that this one is removal of the entire breast, including those axillary lymph nodes. So this is a big procedure. On this one, look at your Pearl of Wisdom. If you have not been reading the Pearls of Wisdom, those are the best things in your book. Make sure you read them and pay attention to them. On these cases, on 492, you're going to want 2 setups, one for reconstruction following that mastectomy. Again, this is to not spread cancer cells. So think of it the same way as bowel, like it's dirty. We want it separate. Cancer is dirty. We don't want to spread it to something else. So we're going to separate it. Okay, on page 493, you'll see your equipment, instruments, and supplies you want to have available. On this one, it has a specific instrument, so I want you to see where it says Alice Adair clamps. Those are Alice clamps that you've already learned that are just a little more fine. And then Leahy thyroid clamps. So there is a picture of this in your orange book, so you can look at your Leahy thyroid clamp for this one. I also want to point out, instead of saline, we're going to use sterile water on this one. You'll see that with cancer cases, we won't always use saline. So we will use sterile water instead on this case because of the cancer. I actually want to look, because of that, at your practical considerations, very last bullet point. This will explain. At the end of the procedure, make sure there is warm, sterile water, not saline, for irrigation. Do not use normal saline to prevent any possible spread of cancer cells. Very different than what we're used to. Hopefully you know already that we use saline irrigation, especially in open belly cases, because that could cause damage to the patient if we put water inside of their belly. So you need to know that saline is always used for irrigation, but there are situations where we're going to need sterile water instead. This is a good example, cancer cases. So that will prevent the spread of cancer cells. On page 494, you should read through these other procedural considerations also, but I want to stop at number 4. So on this procedural consideration, it's talking about nerves, and you need to know these. So the long thoracic and thoracodorsal nerves are identified and preserved. The surgeon's going to want vessel loops to gently retract these nerves. So yes, vessel loops can retract things other than vessels, so nerves that can retract that back gently also. I want you to know the name of those nerves. So the long thoracic and thoracodorsal nerves are identified and preserved during these cases. And as always, at the end of procedures, we're going to make sure the bleeding is controlled and the wound is irrigated. There's your procedural consideration for you. Again, it's telling you warm, sterile water, not saline. Okay, for these cases, there's going to be a lot of drainage, so you're going to need 2 wound drains. So at the top of 495, see that you're going to need 2 wound drains. Now you will make a note on the side on this one. To prevent the formation of a hematoma or a seroma. That is the point of us putting these drains in after this big case. So 2 wound drains, usually placed one anterior chest in the front, the other one more in the axilla. So we'll have 2 drains, and this is to prevent the formation of a hematoma and or a seroma. And you should know both of those terms. Now look at your practical consideration under the drain. It's talking about your dressing. That's what I want you to look at. The incision is usually closed with staples. The dressing is usually a bulky dressing using Krillex, and it's opened and fluffed. So this is a nice fluffy dressing, but I want you to add that it's actually a pressure dressing. So the Krillex is this big white fluffy stuff, and they'll place it on the patient, but they're going to ACE wrap around it, and it's going to turn it into a pressure dressing. Any dressing that is pushing pressure on that wound is considered a pressure dressing. So on this one, make sure you know they're going to use Krillex. It's going to be fluffed, and that will be a pressure dressing once they add that ACE bandage and wrap it around our patient. Okay, that's your breast surgery. I am now to thyroidectomy. So thyroidectomies, as I said, are usually done by ENT surgeons, but that's if it's cancerous, if it's more involved. General surgeons can also do thyroidectomies. Now, in my experience, they do it a little bit differently than ENT surgeons, but the instruments are the same. So I've got a good setup here for you. So you can see the instruments and supplies you need to have set up on your Mayo stand. And a good picture of what the case actually looks like. On this one, I want you to know a little bit of the background. So on thyroidectomy, know, of course, we're going to be removing the thyroid gland, and that the parathyroid glands are related to that thyroid glands, and they're right posterior behind it. And we're going to try to spare those. We're going to try to keep the parathyroid glands. So the next sentence is a post-op complication that I want you to pay attention to. So it's going to talk about tetany. And again, I want you to know that this is a post-op complication. So it says a life-threatening condition associated with parathyroid glands is tetany. Hopefully you've heard of this. This is why we get a tetanus shot, but you can get tetany from this. So this is a post-op application that can happen. When surgery is performed on that thyroid gland, as many of the parathyroids should be identified and preserved. So one parathyroid gland left in place to guarantee the secretion of calcium into the circulation. So it's giving you the exact reason why we want to preserve those parathyroid glands, so we can still get that secretion of calcium into our circulation. Now it tells you if all 4 glands are removed, the patient will experience hypoparathyroidism. So this is going to cause hypocalcemia, so low calcium, that leads to neuromuscular symptoms of tetany. So again, if that wasn't worded correctly for you, you can write it in layman's terms. You need your parathyroid to secrete calcium into the blood. That is why they want to preserve that parathyroid gland. Your next page on the pathological conditions of the thyroid. So let's look at where it says thyrotoxosis. So this is right under hyperthyroidism, or alternate name, thyrotoxosis. So right there, I want you to make your note. You can underline that term and put if untreated. So hyperthyroidism or thyrotoxosis, if untreated, leads to a life-threatening condition. Now this life-threatening condition, go ahead and draw you an arrow, is your last bullet point. See where it says thyroid storm in italics? That's what can happen. That is your life-threatening condition, the thyroid storm. So one complication of thyrotoxosis, if untreated, is this thyroid storm. So their blood pressure, their heart rate, their body temperature are going to skyrocket up when this thyroid storm happens. So these are the pathological conditions it wants you to pay attention to. Very severe, but make sure you're reading through these pathological conditions, and hopefully you added that note and you know that if thyrotoxosis is untreated, it's going to lead to that life-threatening condition, better known as the thyroid storm. And you should read on your thyroid storm in your book, but I'll say it for you one more time. It's going to increase that blood pressure, heart rate, and body temperature up. Okay, now let's look at pathological conditions of the parathyroid. Parathyroid. On this one, I'm going to repeat the same information for you. That parathyroid is going to regulate the blood calcium. So blood calcium concentration is regulated by those parathyroid glands. We want to hold on to those. So now on thyroidectomy, it hits anatomy. So page 497. So know your parathyroid glands. I'm looking at the top center section. Know those parathyroid glands lie on the dorsal side of the thyroid gland, the dorsal side. And if you read down to where it says arterial blood supply, the arterial blood supply is from the superior and inferior thyroid arteries. That is the anatomy I want you to focus on, but you should read through all of it. You will see that it's very vascular, and that's why I have these clip appliers up here ready to clip and cut vessels. There's also lots of silk ties hiding out over here to ligate more vessels. Let's look at equipment, instruments, unique supplies. You need to know two specific instruments for this case because it's different than regular instruments you have learned. So under thyroidectomy instruments, find green loop retractor, and then your Leahy clamp. So green loop retractor and Leahy clamp. The next one I want you to also just know is that you're going to use bipolar in addition to your Bovie. So the specialty instruments are your green retractor and your Leahy clamp. Some people call that Leahy a tenaculum, not to confuse you, but it doesn't actually get clamped on a vessel. So tenaculum is a better term. But Leahy, thyroid clamp, green retractor, and you'll be using bipolar to coagulate on these cases. We always put in a drain at the end of these cases because there's lots of drainage, but that is surgeon's preference. Let's look at surgical procedure, page 498. On this one, I want you to pay attention to what type of incision they're going to use. So a symmetrical transverse incision following those Langer lines. So straight across, just like in your picture on page 499. See on your procedural considerations, it says electrocautery or bipolar cautery. Hemoclips and ties will be used to control bleeding. So that's everything I just went through and what's on your Mayo to control bleeding throughout the case. As you read through your procedure, pay attention to when you're going to use those two instruments I pointed out. When you're going to use the green loop retractor and then that Leahy clamp, and what they could use instead. So you'll see on page 500, the thyroid's elevated with Alice or a Leahy clamp. You'll see a lot of that as you read throughout the book. That's because it's always going to be surgeon preference. So a lap cholecystectomy, you should memorize that and know it step by step. There's other cases where I'm going to tell you to not memorize it step by step because every surgeon's going to do it a little bit differently. So I'll be sure to point that out to you, but don't let that frustrate you if you're reading through the case and it says something like this, an Alice or a Leahy clamp. It's letting you know that the surgeon can decide which instrument they're going to use. You just need to have both available on your Mayo stand. Okay, so you get to see really good pictures of this one and how they're going to remove it. You'll get to see my favorite muscle retracted that you can see right here. The sternocleidomastoid is that big muscle across your neck, and it moves when you turn your neck, and they can retract that back, and a lot of the times the surgical tech gets to hold that retractor. So I always enjoy doing thyroidectomies, but the idea nowadays is to do a very small incision because it's right on the neck, and the patient is going to see that scar every day. So sometimes they will spend a lot of time making a very beautiful no scar type of closing suture so that the patient doesn't have any scars later on. So the only time I see them take that long to sew something up to make sure there's not a scar is for plastic surgery. I've seen one surgeon do that on a C-section also to prevent the scarring from coming back, but they can sew this with certain suture in a certain specific way so that it can prevent the scarring and it's not as noticeable right on their neck. Okay, so most important part of thyroidectomy, your last pearl of wisdom, and I'll end with this. On page 503, maintain the integrity of the sterile field until the patient is extubated, breathing freely, and has been transported to PACU. Emergency tracheotomy is possible. Anytime you're working on the head or neck, we always are ready to do a tracheotomy. So we will go over how to do that procedure when we get to it. I believe in ENT, but when we get to that procedure, I'll go over it step by step because this is saving the patient's airway. It's very important. You need to know what you need to do a tracheotomy and in what step and how to do it safely, because this is preserving the patient's airway. So even though you should already know to keep your sterile field sterile at the end of your cases, with head and neck surgery, especially a thyroidectomy, you're going to be prepared for a tracheotomy. Because of that, you keep your field sterile. You wait till you get a phone call from PACU that says, now you can break down the case. This is opposite from normal. So normally you're done with your case, your patient's waking up, you're already cleaning. You're getting your instruments put away, you're cleaning the room. We're going on to the next one. It's all about time. When it comes to the patient's airway, time should stop. And if people are rushing you, you can say, no, I am protecting the patient's airway. So you're going to keep the sterile field sterile. Okay, so that's my last point. So if you have any questions, feel free to ask me, especially about the specifics and the procedures. So I tried to point out the important parts for you, so I'm not reading the entire book to you. But if you have any questions, feel free to ask me. I have a lot of experience in general surgery if you're just curious and have a question. So send me an email or Facebook message if you need any help. Thank you guys. I'll see you soon.